Hi there, I'm John, and this is actually part 4 of neurologic discussion under your Chronicle of Medical Surgical Nursing. I hope that before you will proceed on this clip, you're able to check the part 1, part 2, and part 3 under neuro concept. Okay, so for this, we will be talking about the different disturbances affecting nervous system. So on top is actually your CVA or your cerebrovascular accident, right? Now, when you say CVA, it means to say that there is disrupted blood flow to the brain. Remember that if you deprive the brain of sufficient blood supply, it will lead to irreversible neurologic problem or neurologic deficits. Now, please do not forget that the risk factors of your CVA are the same risk factors for coronary artery diseases. In short, okay, these two conditions are actually interrelated, right? And plus the fact that if a patient is having a cardiac problem, just like your atrial fibrillation, it will also increase the likelihood of stroke, because if a patient is having atrial fibrillation or patient is having valvular defect, chances are there will be an increased clot formation. That is why do not be surprised that a patient with valvular defect or defects or a patient having atrial fibrillation, you need to give aspirin. Aspirin as a form of an antiplatelet drug. This will decrease or prevent platelet to form a clot, right? So anyway, your CVA has actually 4 common types. So what are the 4 types of your CVA? Actually, you have it there in the book, The Chronicle of Medical Surgical Nursing. So you can use that as your reference. So this is just a supplementary video of the book, okay? So there are 4 common types of your CVA. So what are the 4 types of your CVA? The first is what we call your TIA or transient ischemic attack. When you say TIA or transient ischemic attack, it refers to brain angina. It means to say it is a form of an early warning that the brain is not receiving enough blood supply. Okay? So when you say TIA, the neurologic deficits of the patient here are actually reversible. So how would you describe the neurologic deficits? The neurologic deficits of the patient here are actually lasting less than 24 hours. Can you follow? Not more than 24 hours. Okay? And again, it is reversible. The second type of CVA is what we call your cerebral thrombus. Cerebral thrombus. Now, when you say cerebral thrombus, it means to say that a clot develops inside the brain. So I just want to make it clear. The clot in your cerebral thrombus is a clot that develops, that grows inside the brain. Okay? And when that grows, chances are it obstructs the normal circulation. The third type of CVA is what we call your cerebral emboli. So when you say emboli, it means to say that it is a wandering clot, right? So when you say cerebral emboli, it means to say that the clot originates outside the brain. It could be from the lower extremities, it could be from the lungs of the patient, it could be from the heart of the patient. And mind you, the most common cause or source of clot is actually the heart. Remember, I mentioned atrial fibrillation. So that is what we call your cerebral emboli. Now, take note. Other book, they combine cerebral thrombus and cerebral emboli. When you combine these two, you call that as your thromboembolic stroke. Or, other book, they don't call that thromboembolic stroke. They call that as your ischemic stroke. So take note. Thromboembolic stroke, ischemic stroke, they're the same. So what is the problem here? The main problem is actually clot. Okay? The fourth type of stroke is what we call your hemorrhagic stroke. Hemorrhagic. Now take note. Hemorrhagic stroke, of course, there is bleeding. Now hemorrhagic stroke is actually the most fatal type of stroke because, okay, this is actually brought about by a persistent elevation in the blood pressure. Okay, lalong-lalo na if the patient is having uncontrolled hypertension. Remember, if the pressure is so high, what will happen? If the pressure is so high, the blood vessel ruptures, right? So when the blood vessel ruptures, the blood leaks out. So when the blood leaks out, it compresses the tissues outside the cerebral blood vessel. So the more it causes neurologic deficits. So this is actually brought about by uncontrolled hypertension. Now I just want to stress something. Cerebral thrombus, cerebral emboli, or thromboembolic stroke or ischemic stroke, they usually pass the period of TIA. Whereas hemorrhagic stroke will not pass the period of TIA. Automatic kaagad stroke. Okay? So take note. This too is brought about by clot. This is brought about by bleeding. That is why long time ago, okay, the mortality of CVA is very high because doctors thought that stroke is brought about by clot without knowing that there is another type which is actually bleeding concern or bleeding problem. That is why if you give anticoagulant, if you give thrombolytic drug, if you give antiplatelet drug to patient with hemorrhagic stroke, you're not helping the patient at all. You're killing the patient, right? Because the moment you give those drugs, okay, the moment you give those anticoagulant, antiplatelet, okay, thrombolytic, the more it causes bleeding, right? That is why the mortality long time ago is very high. Good thing we have your MRI now, we have your CT scan. With your CT scan, the doctor will have an idea what type of stroke. Remember, different type of strokes, the TIA, cerebral thrombus, cerebral emboli, hemorrhagic, but they have the same neurologic deficits. It's just that they differ on the severity, they differ on the onset, but the manifestations are the same. So let's try to check the animation of your thromboembolic stroke as well as your hemorrhagic stroke. Watch this. So this is the animation of your thromboembolic stroke. Just a recap. Your thromboembolic stroke is actually a combination of your cerebral thrombus and cerebral emboli. When you say cerebral thrombus, it means to say that a clot develops inside the brain and it causes cerebral occlusion. When you say cerebral emboli, it means to say that a clot originates outside the brain and then accidentally enters or gains access into your cerebral circulation, again causing cerebral occlusion. And when you say cerebral emboli, the clot here usually originates from the heart, especially for those patients with atrial fibrillation. That is why do not be surprised that if patient is having atrial fibrillation, aspirin or your antiplatelet drug will be given to your patient as a maintenance drug. Now look at your animation here. Again, when you combine cerebral thrombus or cerebral emboli, you call it your thromboembolic stroke or ischemic stroke. So bottom line, a patient with thromboembolic stroke or ischemic stroke, the main concern is actually a clot, right? So a clot may originate outside the heart, outside the brain, and then it gains access into your cerebral circulation. So let's try to check it out. So if this is the clot, it lodges inside the cerebral artery. So the distal part of that will be deprived of enough oxygen. So what will happen? The tissues distal to this obstructed blood vessel will die because of deprivation of good blood flow. So that is why patient with thromboembolic stroke, the primary concern in your management here is actually to restore or to improve perfusion. So that is what we call your thromboembolic stroke. So this is the animation of your hemorrhagic stroke. We know that hemorrhagic stroke is the most aggressive type of stroke, and this condition usually is brought about by persistent elevation in the blood pressure wherein if the hypertension of the patient is not controlled. So if the pressure is so high, the blood vessels in the brain rupture because of too much pressure. So it may start from a very simple aneurysm, and then chances are the blood vessel ruptures because of too much pressure. So this is the animation. Look, persistent elevation in the blood pressure. So what will happen is that the blood vessels of the brain here, let's try to check, it ruptures. So when the blood leaks out from the cerebral circulation, the blood compresses the nearby structures, right? So the more it will give you neurologic deficits. That is why if you notice between thromboembolic stroke and hemorrhagic stroke, it is your hemorrhagic stroke that will give you a more aggressive neurologic deficits. So this is what we call your hemorrhagic stroke. Okay, so let's go back. So I hope you appreciate the animations of your thromboembolic stroke and then your hemorrhagic stroke. So this time, let's talk about the different signs and symptoms of the patient with hemorrhagic stroke, thromboembolic stroke. In general, signs and symptoms of patient with CVA. Remember, I said that they have the same neurologic deficits. Now, when I say neurologic deficits, there are only 3 neurologic deficits, right? It could be a form of sensory deficit, motor deficit, or a combination sensory and motor deficits. Mind you that if a patient is having sensory deficit, motor deficit, or a combination, our priority is always safety of the patient. So please do not forget that. Now, in the book, The Chronicle of Medical Surgical Nursing, page 20, you have it there, the different signs and symptoms of the patient, right? I hope you have the book. You try to check it out, page 20. But I need to stress important things about the signs and symptoms of the patient, okay? Now, remember that there are different neurologic deficits. Now, on top, I can still remember on page 20, you have there your visual field deficit, right? So, First is actually your homonymous hemianopia, right? Now, when I say homonymous hemianopia refers to blindness or visual field deficit of the patient of either right or left visual field of both eyes. In short, in homonymous hemianopia, both eyes are affected. And take note, half of the visual field is actually lost. So the question there is that, if you have right hemispheric stroke, saan yung blindness ng patient? Can you follow? Kung saan yung blindness ng pasyente. Now, take note. Now, let's say that this is the head of the patient. Please bear with my drawing. Okay? Now, this is the right brain and the left brain, or the right side and the left side. Okay? Right eye, left eye, ilong, baba, dila. Can you follow? I will incorporate homonymous hemianopia with the paralysis of the patient. Okay? Para isang discussion na lang. Remember, I said that the paralysis in the paralysis of the patient with hemispheric stroke, the paralysis above the neck is actually paralysis on the same side of injury, right? You call it paralysis on the same side of injury as what we call your ipsilateral paralysis. Can you follow? Again, when you say ipsilateral, anong ibig sabihin? Same side or opposite side? Again, it's same side of injury. Same side of injury. Whereas paralysis down the neck is the paralysis on the opposite side of injury. You call that paralysis as your contralateral paralysis. Again, this is the paralysis on the opposite side of injury. Can you follow? So let's try to check. If a patient develops right hemispheric stroke, let's say the right brain is affected, the right hemispheric stroke. So ang tanong, a patient with right hemispheric stroke, saan ang motor deficit sa tongue? Where do you think is the motor deficit of the patient with respect sa tongue? Is it on the right side of the tongue or on the left side of the tongue? Answer, right side of the tongue. Sir, why on the right side of the tongue? Because above the neck, the paralysis is on the same side of injury. That is why a patient with right hemispheric stroke and the patient wants to eat. Where will you place the food on the patient's tongue? Will you place it on the right side or on the left side? Answer, place it on the left side. Never place the food on the right side of the tongue because there is motor deficit. Chances are, if we place the food there on the right side, it causes aspiration. Remember, priority, safety of the patient. Now, what about the paralysis in the body of the patient? Is it on the right side of the body or left side of the body? Remember, in your anatomy physiology, I said that the right brain or right hemisphere controls the opposite side, controls the left side of the body. Remember, we're talking about the body, not the head, right? So a patient with right hemispheric stroke, paralysis is on the left side of the body. Therefore, left side of the body has the paralysis. Therefore, the question, where will you place the things of the patient with right hemispheric stroke? Take note the question here, where will you place the things of the patient? Answer, place it on the right side because the right side, it's able. Am I right? Affected part is on the left side. But if the question in your exam, where will you place the things of the patient to prevent unilateral neglect? So that is a different question, right? So if you be asked, where will you place the things of the patient to prevent unilateral neglect? Answer, place it on the affected side because the purpose is to prevent unilateral neglect. So that is why it's quite tricky. Therefore, you have to read the questions very well. Can you follow? Now, another thing. With respect to the blindness of the patient, remember we mentioned homonymous hemianopia. Now, homonymous hemianopia refers to blindness or visual field deficit of either right or left visual field of both eyes. Therefore, ang tanong, a patient with right hemispheric stroke, saan yung blindness ng patient? Is it on the right side or on the left side? Okay, let's make a drawing here. Let's say this is the right eye of the patient. This will be the left eye of the patient. Okay? So tell me, right hemispheric stroke, saan yung blindness ng patient? Right side or left side? What's your answer? Right or left? The correct answer is left side. So your technique, kung saan ang paralysis sa katawan ng pasyente sa katawan kung saan yung paralysis sa katawan, dun ang blindness ng patient. Therefore, if you divide this into two, right, left, saan yung blindness ng pasyente? Right or left side? Left of both eyes. Remember, homonymous hemianopia is blindness or visual field deficit of either right or left visual field of both eyes. So in this case, the paralysis of the patient, technique, sabi natin technique to, kung saan yung paralysis sa katawan, dun ang blindness ng patient. Therefore, yung dalawang mata, hindi makakita sa left side. Can you follow? Ayan. Oh my God. Tuko, please. Please don't mind that because it's already 11:15 in the evening. So again, let's go back. So, nawala ako sa passing. So again, right hemispheric stroke, the blindness of the patient is on the left visual field of both eyes. Sir, sabi mo kanina, above the neck, para kay paralysis is on the same side of injury. Correct. We are talking about blindness. Ito is paralysis. So please do not mix them. Okay? Iba ang paralysis, iba yung blindness. Homonymous hemianopia is a form of sensory deficit. Paralysis is a form of motor deficit. Yung sinasabi natin na same side, above the neck, opposite side, down the neck, that is for motor deficit, that is for paralysis. Can you follow? Please do not confuse that with your blindness kasi iba yung blindness, iba yung paralysis. Okay? So, ang technique lang natin dito, kung saan yung paralysis sa katawan, dun siya hindi makakita. Therefore, a patient with right hemispheric stroke, hindi makakita yung dalawang mata sa left side. Therefore, if you be asked on your exam, you are the charge nurse and you need to give health teachings to your patient. You need to give instructions. On what side will you face the patient? Alam natin na ang pasyente na may right hemispheric stroke, hindi makakita yung dalawang mata sa kaliwa or on the left side. Therefore, where will you face the patient? Face the patient on the right side na kung saan nakikita ka ng pasyente. Remember, when you give instructions, when you give your health teachings, the patient must be able to see you. Am I right? So face the patient on the right side. So please do not forget this. Okay? Let's try to recap. Patient with right hemispheric stroke wants to eat. Where will you place the food on the patient's tongue? Answer, left side of the tongue. Patient with right hemispheric stroke, right, kanan. Where will you place the things of the patient? Answer, right side. Pero pag ang tanong, patient with right hemispheric stroke, where will you place the things of the patient to prevent unilateral neglect? Answer, left side. Can you follow? Patient with right hemispheric stroke, you need to give instructions or informations or health teachings. On what side will you face the patient? Answer, right side. Because right hemispheric stroke cannot see, both eyes cannot see on the left side. Can you follow? Because of homonymous hemianopia. Can you follow? Please do not forget that. Now, aside from your homonymous hemianopia, okay? Aside from your homonymous hemianopia and of course, your paralysis, please be reminded that because of paralysis, it will increase the risk of tissue breakdown or your bed sore. That is why one parameter being used here to evaluate bed sore is actually the Braden scale. Can you follow? Your Braden scale is actually an assessment tool to evaluate progress or severity of your bed sore. Okay? Now, to prevent bed sore or your pressure sore or pressure ulcer, please be reminded that we have to turn our patient from side to side. Now, question, with respect to bed sore, can we delegate this, a patient with bed sore, okay, to a patient, can we delegate a patient with bed sore to an LPN or LVN? Answer, no. Can you follow? Regardless of the stage of bed sore, which is stage 1, stage 2, or stage 3, patient with bed sore, remember, it cannot be delegated. Can you follow? Now, another thing. With respect to visual field deficit, so you're done with your homonymous hemianopia, right? Second is what they call your loss of peripheral vision. Now, when you say loss of peripheral vision, it means to say, hindi mo nakikita yung side. There is loss of peripheral. Yung nakikita mo gitna lang. Am I right? Or, ibig sabihin kung gitna lang yung nakikita, you call that as your central vision. Can you follow? So, another name of loss of peripheral vision is central vision. Or, kung loss of peripheral, gitna lang nakikita, parang nasan ka? Parang nasa tunnel. Am I right? Therefore, another name of loss of peripheral vision is central vision or tunnel vision. So ano ang dapat tandaan pag yung pasyente po ay may loss of peripheral vision? Well, you have to instruct the patient to scan the lost visual field. Do not forget that. Another thing is your diplopia or double vision. Because of diplopia, remember, dalawa yung paningin niya, right? Double vision yun, right? So anong importante? Will you stress the quantity or the quality? Of course, you have to stress quantity, not quality. Can you follow? So you have to inform the patient ilan yung kutsara, ilan yung tinidor. In short, you need to stress quantity because of double vision. Am I right? And with respect to double vision or diplopia, anong dapat tandaan as a nurse? You have to cover each eye of the patient alternately per day. Can you follow? Cover each eye alternately per day. Please do not forget that, right? And another thing, with respect to motor deficit of the patient, I mentioned, paralysis, I mentioned that, and of course, please bear in mind that a patient with stroke, they have this what we call dysphagia, right? Or there's difficulty of swallowing. Because of dysphagia, priority is safety of the patient. That is why patient with stroke, if you want to feed the patient, you need to elevate the head of the bed, right? And take note, you need to avoid thin liquids because thin liquids will increase the likelihood of aspiration. Remember, priority is safety of the patient. So that is what we call your stroke. Please do not forget that, right? And with respect to your stroke, the initial test is actually your non-contrast CT scan, okay? Please be reminded that CT scan, X-ray, they use radiation. That is why if this test uses radiation, okay, the chest CT scan and your X-ray, they use radiation. Okay, if the patient is actually babae, you have to check when was the last menstrual period because a pregnant cannot be subject for X-ray test or your CT scan because of what we call radiation exposure. So you have to check when was the last menstrual period or if the patient is pregnant. Okay? So aside from that, we have also your MRI. Can you follow? So you have it there in the book, the different tests. Okay? With respect to management, I mentioned anticoagulant, I mentioned antiplatelet drug, and then your thrombolytic drugs. I made a video with respect to anticoagulant and antiplatelet. So with respect to your anticoagulant, antiplatelet, I want you to familiarize the therapeutic level. Can you follow? And what specific test is best for this specific medication. For example, if your patient is taking heparin, what is the best diagnostic test? What is the normal range? What is the therapeutic level? I made a video on that concept, so I want you to check it out. Okay, so I will no longer discuss it here in the video clip. So I want to check it out. Okay, actually it's nasa YouTube yon. So I hope you subscribe on my channel. Okay, so that is what we call your CBA. Now, another concern with your CBA is that actually the surgery, right? So the surgery here, your head surgery, it can be a form of craniotomy or craniectomy. So nevertheless, this, ayun na naman siya, yung tuko. Best friend ko yan eh. Okay? Now, with respect to head surgeries, it can be a form of craniotomy or craniectomy. So nevertheless, these are all head surgeries. Tandaan po natin, in any form of head surgery or head surgeries, the most common problem post-op is actually increased intracranial pressure. Tama po ba? That is why if there's an increase in the ICP, you have to elevate the head of the bed of the patient post-op and make it sure that the head of the patient must be center or neutral position. Never allow the head of the patient to face on one side or other side. Because if you allow the head of the patient to face on the side, what will happen? You compress the blood vessels on the sides of the neck. Am I right? So if you compress the blood vessels on the sides of the neck, venous return is affected. So what will happen? Blood will congest in the upper part, increasing ICP. That is why if there's increased ICP, elevate the head of the bed, and head must be neutral or center. Can you follow? But if the question in your exam is, how will you position the head? If the purpose is to drain secretions to prevent aspiration, then that is the time that you move the head or you let the patient head face on the side. That is to facilitate drainage of secretions. That is why you have to read the questions very well. Can you follow? So wag niyong pangunahan yung tanong. Can you follow? You have to read the questions word per word. Clear? Okay, I hope so. So that is what we call your CBA. Okay? So let's proceed to another problem, and that is actually what we call your Parkinson's disease.